Okay, welcome to SNU Hospital. This is third TAVI case today. I'm H.S. Kim. My co-operator is Dr. J.Q. Han and Ji-Hoon Kang, and Professor Karam Nam, anesthesiologist. I prepared a TAVR-IN-TAVR case. In other words, evolute implantation for a failed sapien. Okay, slide first. 85 years old female who underwent TAVI using sapien XT 23 millimeter 7 years ago. She disappeared in 2017 and reappeared last month, complaining angina and dyspnea. She told me she took medication from other hospitals, including aspirin. Coronary angiography last month revealed insignificant coronary artery stenosis because at that time, TAVI 7 years ago, coronary obstruction possibility was one issue. Echo revealed severe AS plus no particular comorbid condition plus aspirin and statin and other diuretics. Creatinine level is 1.1. Target is degenerated sapien XT 23 millimeter valve with severe stenosis. I planned evolute in failed sapien plus cardiomegaly. She experienced recently angina and symptom of heart failure. Sinus rhythm with LVH plus. Echo revealed normal LV contractility with severe prostatic AS plus. Valve area is 0.6, mean gradient 40 plus. 7 years ago, the issue was the possibility of coronary obstruction because, first, presence of calcium chunk on the left leaflet. The second, left main ostial height is low. Third, space of sinus valsalva is narrow. These three factors are really important determinant of coronary obstruction during TAVI. On the right side, better, plus. So 7 years ago, when we implant sapien XT, we protect the left main by inserting guiding catheter, balloon catheter, and wire, as shown here, plus ballooning. And on the right side, immediately after implantation of sapien, we can see the maintenance of coronary flow to the left plus. But when we see more precisely, there is not a natural appearance, a little bit pinched left main. On the right side, there is some weak dye contrast image on the left main ostium, suggesting external compression, probably from calcium chunk on the leaflet. Plus, at the time, sapien was excellent, no significant leakage, plus. Because today, we measured the internal diameter of sapien XT 23 at the annulus level. That was 20 millimeters, plus LVOT 22, plus. We can see the degenerated sapien XT at 7 years, plus. Bedside is coronary height. From the bottom of valve, just 10 millimeters on the left, 14 on the right. As the junction height is also not high, 17 or 15, plus. The other bad point is narrow sinus valsalva and ST junction diameter. ST junction, about 22 or 19. Space of sinus valsalva left and right, less than 30 millimeters. plus a short membrane septum diameter. But in with TAVI or TAVI-in-TAVI, there is less chance of aggravation of conduction disturbance because of protection from the protection of the first valve from the conduction valve, conduction system. Plus, the important thing to determine the coronary obstruction during TAVI is distance from valve to coronary ostium, VTC length. In this case, it was right 2.6, left 2.7. Please indicate where VTC. 2.7, 2.6, okay. So it is less than 3. So if we push external force into the SAPIEN XT, the frame of SAPIEN XT may get closer to the left main ostium or right coronary ostium. That is one issue. Plus, to summarize the measurement, internal diameter of SAPIEN 23 is about 20 millimeters. And coronary height is not high from the bottom of SAPIEN XT. As the junction height is not high enough, about 17 or 15, not large. There are issues of isolation of SD sinus of space because of low and narrow SD junction. Plus, here is the SAPIEN XT23 that we implanted 7 years ago. Height, about 14 millimeters. Plus, thus, in this case, we decide to do Avalute Pro. Annulus is 61 millimeter. That corresponds to 23 millimeter Avalute Pro. With oversize index, about 18%. Acceptable size. Plus, I prepared the 3 issues. The first is valve selection for TAVI-in-TAVI. In this case, I select Avalute Pro for failed SAPIEN XT. Second, optimal positioning of Avalute valve in failed SAPIEN XT. Third, coronary obstruction risk. Plus, for the first issue, when we compared with TAVI and reduced surgery, compatible. In early time point, with TAVI is better. Plus, the second issue is TAVI-in-TAVI, which valve should be selected? SAPIEN versus Avalute. The first is pressure gradient. Pressure gradient is lower and better with Avalute. PPM, severe PPM prevalence is lower and better with Avalute. Leakage is not different between two. And on the right, lower, mean pressure gradient is also better with Avalute. Thus, in all the virtue, Avalute is better than the failed intra-annular surgical valve or failed intra-annular SAPIEN valve. Plus, how to position the Avalute valve in the failed SAPIEN valve. The higher, the better in terms of orifice area and pressure gradient. My target is just 4 millimeter ventricular, or not ventricular, 4 millimeter below neo-annulus of failed valve. Plus, so let's look at the measurement on the left. Failed SAPIEN XT23. On the right, Avalute Pro 23 that we implant today. On the left, frame height is about 14, B 23 millimeter, but actual internal diameter is about 20 millimeter. On the right side, the important measurement is F, skirt height is 13, and E, commissure height is 26. E minus F, that is the zone of functioning valve of Avalute Pro. Thus, when we implant Avalute, just about 4 or 6 below the SAPIEN valve, we may have about skirt height above annulus is about 7 millimeter. Thus, that is just half of the SAPIEN valve. That would be acceptable position regarding the obstruction of coronary ostium. Plus, coronary obstruction risk is very high. On the right side, red bar is actual instance of coronary obstruction after VIV-TAVI, significant higher in the first TAVI. Plus, if obstructed, most of the patients die. It's very fatal. Plus, how to expect the obstruction risk? I mentioned before 3 factors, but that is a kind of a neo-TAVI procedure. The VIV-TAVI procedure, VTC, distance from valve to coronary ostium is very important factor to determine the coronary obstruction during VIV-TAVI or TAVI-in-TAVI. In this case, less than 3 millimeter. Thus, I think it's a little bit dangerous. Plus, to prevent coronary obstruction during VIV-TAVI, basilica procedure may be considered, especially for the externally mounted valve, because externally mounted valves means the leaflet is outside. It's easily obstruct the coronary, but SAPIEN is a little bit different from the externally mounted surgical valve. Plus, thus we just do pre-engaging the left system using guiding catheter and the balloon and the wire. But to summarize today's case, TAVI-in-TAVI, valve selection, Avalot Pro 23, 18% oversizing for the failed SAPIEN XT 23 millimeter valve. Okay, if there's a comment,
Okay, Dr. Kim, you already addressed the most important issues in the TAVI-in-TAVI, so thank you for the lecture. Dr. Grubek, do you have something to add in addition to this presentation?
First of all, I would like to thank you all for having me back again. It's wonderful to be here and listening to Dr. Kim as usual, very detailed, and he gave a lecture about everything. While he was talking about this, I was reflecting myself what I would do here in this particular case. I think personally I would probably not use an Evolut. I would probably use a SAPIEN for the reason of coronary access. The Evolut situation and supraannular, having a high implant with supraannular leaflets, given the age of this patient, I don't really think that the gradient would make such a big difference. For me, it is probably more important to take care of the coronaries. So while I'm obviously respecting his choice, given his arguments pro Evolut Pro, in this case, I would probably take another SAPIEN.
Okay, so very good comment. So, Dr. Hashida, what do you think? Selection of
thank you very much.
The risk of coronary occlusion.
Yeah. Actually, I don't have any personal experience for the TAVI-in-TAVR procedure, and the VTC distance is quite short, and I'm afraid of the risk of coronary obstruction. And I understand the decision by Dr. Kim that the Evolut doesn't push the stent stroke outwards that much, and I would protect the coronary artery, especially for the left main, for this specific case.
So, do we need to protect right coronary, left coronary only?
If possible, maybe both, because the VTC of both are very short. But I think left main is more important.
why to protect the right coronary artery? Because it clearly originates above the upper struts of the valve. So, and I would also add a comment integrating what Dr. Gruber said. So I would also choose a sapien in this case, and the reason is coronary protection. We published a large registry on coronary protection, and we saw that the greatest number of stent thrombosis occurred after an evolute, because with evolute you have to use longer stent, and then the stent is between the vessel, the aorta, and the strut, and probably the valve continues to push, and this may be the reason because the valve had higher rates of stent thrombosis. So for all these reasons, I would use also a sapien in this case.
I think that when it comes to coronary obstruction risk, the patient has a very short VTC and the low coronary height, but the previous valve internally fixated bioprosthetic leaflet. So as you know that it is usually associated with very low risk coronary artery obstruction risk. So I don't know about the coronary
Pressure
obstruction
profile.
risk for this patient. So pre-valve alone is very helpful for predicting coronary obstruction risk. What do you think about that?
So testing the risk of coronary obstruction by ballooning. So actually, I don't believe that.
You don't believe
Many
that?
times
저
the
네이버를
result
보여주면
is
어떡하노?
not predicting the coronary occlusion. But if the right coronary is above the valve, I think, so if I implant the sapien valve, is very straightforward. To align the valve with the previous upper side of the XD valve, there is definitely the second stent will be below the right coronary, but I'm not sure the core
Pressure
valve
profile.
impact the core valve. But the core valve is
In a
associated with
small.
low risk of coronary occlusion. Maybe it works, so I have no idea. Okay, you go ahead and
Okay.
show us what will happen.
We performed double tracing, as you can see,
So you protect the right side or left? Left side, right?
left side only.
Yeah.
Pressure profile is very severe stenosis. Valve area is 0.6 square centimeters, but pressure gradient is very severe. And you can see delayed uprising of systolic pressure in aorta. Okay, angio, this is root angio to check both coronary arteries. As you noticed, RC ostium is above the frame. Left ostium is at the level of upper part of frame. But there is some narrowing, but actually there is no change since 7 years ago. Plus. Here is a left angiography. Good. Plus. We inserted wire into left ventricle. Plus. It's not so easy. Plus. We introduce so from now on, I'd like to proceed the procedure.
So
Okay.
talking about I'd
했나?
like to talk about the method of protecting
아니,
left
바꿔놨어요.
coronary.
다이로 바꿔놨고.
You put just wire or the balloon stand.
Or guiding, or extension cassette.
Guiding extension. So you put just wire, Dr. Kim?
No, balloon catheter.
Balloon?
Just wire is, I believe it is too weak. Thus, I always, during implantation, I a little bit retrieve the guided catheter out of the left main ostium. For this position, I think insertion of balloon catheter would be helpful to stabilize.
So the balloon is inside the coronary or outside?
Yes.
Inside
Inside.
the coronary. I can't see it clearly.
Here.
But sometimes the valve between the calcification, even after the ballooning, the stent cannot go in sometimes. So do you think about that risk?
Okay.
Dr. Kim, when you're implanting the evolute, do you have any plan on where to implant the valve? How high or how deep?
I think I have a plan to implant about 6 millimeter ventricle below the low bottom of sapien. Then we can position the uppermost level of outside skirt is midpoint of sapien. This is far low the coronary ostium. So it's a little bit deeper, but similar to TAVI.
So valve-in-valve case, the even deep position of the low position of the core valve does not necessarily relate to the complete AV block. Is that right?
I believe so.
So can I make a comment on coronary protection? We generally use a different technique. So in cases in which we are sure 100% that the coronary artery is going to be obstructed, we place the stent at the ostium in the snorkeling position. And this is because we are afraid that if you leave the stent in the LAD, when you pull it back, the stent may get entrapped across the stent frame. And so this is the reason why we place the stent in the final position.
Julia, would you protect the coronaries in this case?
On the left side.
Coronary, definitely yes, because the Sapien XT is a STJ, so the neoskirt is going to seal the left coronary artery at STJ. I'm not afraid about the right, but definitely about the left. What about you?
How do you protect the left coronary? Stent or balloon?
Stent. I would have put a stent.
Another point is that inside of previous the TAVI valve built, I think it's the more slippery than the native valve. Is the problem of positioning? So I have a very little experience about this, so I'd like to ask Dr. Grube. It's more challenging. Is it more challenging to deploy the core valve inside of a TAVI valve because it's slippery? Is that right?
Yes.
Yes.
Because the degenerated
무슨 밸브를 가이딩 카테터를 빼야 되나?
the degenerated valves are sometimes tenting, and it's a little bit more difficult to get into the left ventricle. So what I would probably, but the wire is in already, so
자, 이걸 빼.
that's going to be okay. I think as far as the valve size is concerned, I wouldn't oversize. I would just
자, 그러면은
try to
이거를
compress
필테를
as
빼야
much as
된다는 이야기.
possible
그지?
to keep the gradient down.
볼까?
여기서 그냥 하는 거예요.
So is there
Just one question about mitigating coronary obstruction risk rather
알겠어?
than a
그냥
stent.
넣는다.
Was the original valve commissure aligned in some manner? Would there be a role for balloon-assisted basilica to the XT valve in
따라와야지
such a
뭐
way
하노?
that you mitigate XT valve coronary obstruction? I just wonder where the wire is and the stent to protect the coronary. Maybe a balloon-assisted basilica may work if the THV originally was aligned appropriately. I mean, this is a high-risk case.
자,
So
YST.
maybe we think about the mechanism of coronary occlusion if it occurs. So not because of the valve leaflet
Okay.
inside of a
저장하고요.
stent, but because of the remained pushed away leaflets outside of a stent. So basilica, do you think basilica will work? I don't think so actually.
Yeah, usually outward fixed valve leaflet case is basilica is useful. The TAVI valve internally fixed, so not useful.
So is there any
Okay.
special technique
From now on.
for the
Deploy.
deploying the stent inside of TAVI valve, which is
slow.
more slippery?
Deploy. 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 Deploy.
Yeah, let's see how
Deploy.
slippery
Deploy.
it is.
Deploy. Deploy. 왜 이렇게 그걸 됐어? 예? 자, deploy. I think the deployed. It is about 6 millimeter below sapien. Deploy.
So deeper than usual approach, is that right?
Yeah. Deploy. Usually they recommend the lower edge of alveolar at the lower edge of sapien. Deploy.
But the previous
Deploy.
sapien valve position a little bit deep.
Deploy. Deploy. Pressure 낮네. Deploy. Deploy.
Dr. Grube, is
Deploy.
do we need to targeting the lower position
Deploy.
than usual native valve?
Deploy. Deploy 어때? 이렇게 향해.
TAVI.
이렇게.
No, I would.
Deploy.
I would probably go even a little higher because I'm not concerned about, the
Deploy.
rhythm problem. And
Deploy.
I would take it higher because we know that the anchoring in a degenerated sapien valve is pretty good, so I'm not concerned about
Blood
the
pressure is
approach.
dropping.
I
Deploy.
would go a little higher
Deploy. Deploy.
than this.
deploy 쭉 가. 스톱. 저장하고요. 자, 온라인 맞춰보고. 프레셔. 스냅까?
Is there
A little
any
bit
risk
deep.
Very good.
Very good.
Deep.
If a valve is too slippery, maybe it can jump in to the LV. Will it happen or not?
I think a little bit higher position may be good. 근데 혈압이 낮아가지고 마음대로 못 하겠네. 자, recapture,
Blood pressure is
recapture,
low.
하겠습니다.
rapid recapture.
하겠습니다.
They are slippery.
Right, yeah. There is a risk of jumping in. So Dr. Gruber
more,
recommended
more.
a higher position as you.
다 했어요.
Yeah,
Okay.
The problem with a high with a high implant obviously is also that you have to know that
혈압을 쭉.
that you do the right thing and be able to still access the coronary. So don't put it too high.
If blood pressure return, I try once again.
So just a technical observation. Notice that Dr. Kim did not use rapid pacing during the last deployment. Anybody use rapid pacing?
I just target the lower edge of alveolar a little bit higher, just 1 or 2 millimeter ventricular, because about 4 millimeter ventricular, it is slippery, so dive in.
Yeah, that's
Okay. Blood pressure is increased, so I re-enter.
So again, using rapid pacing may probably help for this issue.
Okay. Deploy, 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 deploy. 쭉 천천히 deploy, 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 deploy. Stop.
아직 안 나왔습니다.
저장하고요. Deploy, deploy.
The valve is now coming out.
100번 pacing. Deploy, deploy, deploy. 또 툭 들어가지. deploy. 천천히 deploy. 푹푹 돌리지 말고. deploy.
We also go up to 180, so for the very last deployment.
deploy. deploy.
What
Deploy.
is the best
Deploy.
deployment
깊이
view?
떨어집니다.
지역 deploy.
아래요, 아래요. And the valve alignment view.
아이,
Valve
돌리는 것도
valve
못하나.
doesn't matter, I think. We have the important thing is align the upper part, lower part.
저장하고.
종이가 잡힙니다.
자, pressure. good. 자, 쓰네. align 맞나?
Yeah.
It's better.
Okay, looks nice.
3
그
millimeters.
에코가 TT가
네.
So,
TT가
Dr.
자.
그룹의 Dr. 하야시다.
한번 볼까?
Is the
다른 뒤로
position is
LA요.
okay? Okay.
Looks great.
그 에블루트 얼라이먼트를 좀 맞춰볼까?
잘안
안 보이지? 오케이. 자, 그럼 사피안 얼라이먼트. 오케이. 사피안 맞추고. 쓰네.
Yeah. Minimally and the coronary is intact.
In this
Okay.
situation, we have to wait 5 minutes to wait with pacing.
Now pacing.
페이싱 오프. 야, 좀 들어가면 자동적으로 오프를 해야지. 혈압이 너무 높아요. 남가란성이 완전 롤러코스터. Okay, I think TT is not helpful because of the. But
Yeah.
TT 한번 볼까?
I think so.
The final release step is very important because it is slippery.
Yeah. But the Dr. Hayashida and the Dr. Grube agree the position is good.
I mean, you know, with the sapien, it's a little bit because you're losing the advantage. If you implant a little bit too deep, then it's not supraannular anymore. Then it's really intraannular. On the other hand, if you put it too high, then you're risking the coronary obstruction. So this is a very fine line. I think he's done a beautiful job.
Yeah.
Plus, he's very happy. He's very relaxed. It's always a good sign.
Okay, can you see the dirty TT image?
Yeah.
Okay. So in this point, I like TE and the general anesthesia, especially for live demonstration.
Dr. Kim, you have 5 minutes to go.
Okay, then just we are going to final release step for prevention of pop-off. So I retrieve the wire and just a little bit push on the delivery system, then slow release. Start, release,
Release.
release,
Release.
release,
Release.
release,
Release.
release,
Release.
release.
Actually, I'm not sure about the
Release.
BTC measurement. So
Release.
BTC is less than 4, the risk of coronary
Release.
occlusion, but the valves can
Release.
move the
Release.
opposite side of calcification.
Release.
So calcium is in the non-coronary
Release.
calcium, then the stent can be pushed towards the left main coronary, but
저장하고
calcification, a lot of calcification left
final
coronary
release.
calcium. It doesn't matter how low
Release.
is the BTC. So
Release.
what do you think?
release,
Is that right?
release,
다 나왔습니다.
release.
하나 덜 나왔습니다.
쭉 릴리스.
다
아직 안 나왔습니다.
끝까지 돌렸네.
That's why we protect the coronary artery many times. And
아직 안 나왔.
we have seen very few
다 했어?
네.
compromise of the left coronary artery.
오케이.
Sometimes right
저장하고.
coronary is compromised rather than left
자, 리트를 바뀌어요.
because of the
이거 좀
severe
잡아주고 있는 거.
calcification
실수로
left.
잡아주세요.
Anyway,
빼지 마. 내가
It seems
뺄게.
that nobody is listening to me. Okay, beautiful. Beautiful.
이제 잡았어요. 저 Y 스테이.
네, 와이 잡고 있어.
Did you feel, Dr.
Capture.
Kim, did you feel that the stent inside the stent is slippery or not? Looks like a very
If the size discrepancy is very severe, then always a kind of vector force applied, thus it is always move. Too shallow, pop off. Too deep, pop down.
But
It
in this
depends.
case-
It depends on the size discrepancy between two valves. Of course, compared with native AS, I think failed valve is a little bit more slippery. Okay, 출수할게요. 자, 준비됐죠? 좀 누르고 Y 스테이 하고요. 밑에 한번 가볼까? The abdominal aorta is very calcified. That's a little bit difficult.
I do have another question to Dr. Kim and maybe to the panel.
자, Y,
What we would use in a
Why
valve
is the- okay.
situation, we would probably use protection of the brain. I know this is not a good topic here in Korea nor in the rest of Europe, but I think valve-in-valve situations are something that we should at least consider protecting the brain. I would just like to bring this up.
Yeah. So the cerebral protection device has been used at very few cases in Korea and one or two centers, but the recent TAVI result was not so convincing. So
Y.
do you Dr. Grobe, do you use a protection device?
I'm sorry?
Do you use a cerebral protection device?
Y 스테이 하고요.
Yes, I do. And I do believe that, there are certain things in medicine that you cannot test or prove with randomized trials. Every randomized trial has an advantage. You can always criticize even randomized trials. The reason why this was done, this trial was done, was obviously to get reimbursement and get some clearance as to when maybe we should be using it or not. And you can see there's a big difference between the results, statistical difference between Europe and America. So many things are coming into it. I just believe that a stroke is such a devastating complication that I feel that I'm obliged to do everything possible, regardless of statistics, to protect a patient, to protect the patient's brain. That's my personal opinion. I respect the results, obviously, but in this case, I would probably use protection.
So there are a lot of debates even in the European Society of Cardiology meeting and after the presentation of the meeting. So maybe protection device available in Japan, Dr. Yoshida? No?
Unfortunately, it's not available. We are always close with the new
자, 코로나리 한번
Debate
확인해
will
보죠.
go on. So we have
Flashing
just
over.
1 minute, Dr. Kim, to wrap up this beautiful demonstration.
그리고 퍼즈하고 코로나리.
Dr. Kim?
Yeah.
Yeah, we have 1 minute left. Please wrap up this case.
Enjoy. We are not finished yet. 자,
Nice.
You're checking coronary.
코로나리.
We
Okay,
have seen the coronary by the artography already.
Beautiful. Very,
Okay,
very nice.
I'm going to remove the coronary system.
So this is, a tricky.
Can you show us the final angiography within 1 minute?
Yeah, just pigtail. Okay. Y stay. Too short.
we can come back
okay.
the
Fine.
40 minutes later.
Are you going to come back to me?
Yeah, just
Okay, then, okay, I can show you. Andrew, not
Very,
final.
very nice.
Okay.
Very nice.
Andrew,
네.
준비됐어요?
okay, very nice. Very
Okay,
nice. Even if
see you later.
Yeah, see you later. Okay. Thank you very much, Dr. Kim, for a nice demonstration of TAVI-in-TAVI.
We measured the pressure gradient between two chambers. Peak to peak pressure gradient was about 20 millimeters of mercury.
20.
Even though we implant evolute at a high position, still there is a pressure gradient about 20 tall. Thus, if we implant sapien, pressure would be more. Thus, as you can see, we performed post-ballooning because there is some gap on the left side, on the left cusp.
Yeah, I can see that.
Plus. So we performed post-ballooning 19 millimeter ballooning cautiously. Okay, we can see the expansion of valve and no obstruction of left main flow.
Okay.
Once again, on the expanded evolute frame is expanded.
And sapien valve too.
Plus, then coronary flow is maintained, then pressure profile improved. Peak to peak pressure gradient is less than 10 torr.
You know, he's really pushing his luck.
Okay. No. We are performing on the scientific basis. Okay, Angel, once again.
Tullio, what do you think?
Yes, he's pushing his luck. I agree. So, but I mean, it's very interesting to see the final result because I think coronary occlusion did not occlude because there is a waist on the left side. You see that the valve doesn't go all the way through the left coronary cusp because in this way the neoskirt would have closed and do the sealing at the STJ level because the valve gets to the STJ level. So this is the reason because the valve didn't occlude it. And actually, I could not have think about that.
Yeah. Well, we know him. He wants to be perfect in all aspects.
Yeah, I agree.
So I think it's a great, beautiful result.
Okay. And the final gradient is a 10 millimeter mercury, is that right?
Yeah, peak to peak.
Great case.
And interesting finding is AR index is improved also from 20 to 23. Especially new index that we proposed was 3.8 to 4.3. That's pressure gradient and regression fraction is all improved. So I'm really satisfied at this result.
Okay, very
Angel?
great case, and we need to come back to Hyo-Soo University. So please wrap up the case.
Okay, I presented 3 TAVI cases today. The first, accurate neo, 2. Second, failed core valve case treated with Sapien Ultra 3, 23 millimeter valve. The third is failed Sapien XT case treated with Evolute Pro. Thus, I think such kind of TAVR-in-TAVR case will increase in South Korea also. Thus, we have to prepare the skill and experience to meet such kind of cases. Thank you very much for your
Great case.
attention.
Congratulations.